So I wanted to tell you about a medical doctor, Dr. D, who a couple of years ago was diagnosed with cancer, which is a physical condition, but then obviously got booked off from work and had to undergo treatment, which included surgery as well. And a few months later, while she was still off work, her oncologist referred her to a psychiatrist for intervention because she was really struggling emotionally and psychologically with the trauma of the diagnosis, as well as the medications and the treatment. So she started seeing a psychiatrist who diagnosed her with adjustment disorder and differential diagnoses of depression and premenstrual dysphoric disorder. And she was put on medication and treated for another few months while she was out of work. So her symptoms were definitely alleviated by the medication. Her cancer treatment was going well. And between her and her doctor, they decided that she was ready to go back to work. So in July of that year, she returned to work as a doctor in a public health institution, a large public health institution. And I'm mentioning that because I know that you know, or you can imagine what sort of what the job would look like in an environment like that, and the kind of demands on a medical doctor, for example, in a oversubscribed type community level clinic where she was working. So she went back to work in July, and going back to work in this instance literally meant that from the one day to the next, she stepped back into the exact same position and with the exact same job demands, and nothing having been addressed or changed or intervened or anything like that in her work environment, or with the job that she was doing, or the job tasks or anything like that. So almost immediately, but about 3 or 4 weeks into her return to work, she started presenting with a lot of symptoms and entered a relapse. So the symptoms that she displayed at work were very disconcerting and in some cases bizarre, manifested in bizarre behaviors. She was verbally aggressive towards co-workers, towards patients. She was disruptive. She showed manic behavior. And of course, her work performance deteriorated tremendously. She wasn't following treatment protocols with patients. And it took some time for her employer, in the form of her line manager, to convince her to go back to her doctor. So her doctor saw her and she was immediately booked off again from work and started on new and different and added medication. And then a few months later, she attempted another return to work. At this point, her diagnosis was revised as schizoaffective disorder, which I'm sure that many of you know that it's a psychotic disorder, but with mood elements, and would be classified as quite a serious mental health condition. And then she was, again, her medication was changed, and she was booked off from work for another few months for recovery. So the year after, her doctor and herself were at the point where they decided that she is about ready to go back to work again. But at this point, an occupational therapist was brought in to do an assessment about her ability to go back to work, which involved, I think Lindsay mentioned, and Misha as well, how this involved an assessment of both the work environment and the job function, the job tasks, the demands, as well as an assessment of Dr. D, her abilities, her presentation of the health condition, and her level of functioning. So that the assessment was done, and she was found to be asymptomatic and to have regained a level of functioning that would allow her to go back to work. But what was identified, for me, it seems quite obvious, but from the work environment, is that no interventions or any sort of interaction or engagement was ever made between anyone and the workplace. And the things that had happened when Dr. D was ill, and the kind of behavior that she displayed, left staff members, co-workers specifically, with fears, with anger, in some cases, a complete breakdown in trust in terms of her ability to do the job, or just as a trust as a co-worker. So the work relationship had suffered tremendously, and none of this had been addressed or explored in any way. And so the OT made a recommendation that some intervention needs to take place in the workplace, with co-workers, and work preparation need to be done before Dr. D can go back. Part of the work preparation also involved the OT working with and having discussions with the line manager and supervisor of Dr. D about what a return to work would look like, and what sort of reasonable accommodations may need to be in place for her to come back to work. So, and bringing our minds back to reasonable accommodation, which in some instances, especially where physical disability or physical conditions are concerned, could be quite easy to, not easy to identify, but concrete, and easy to understand. With mental health conditions, it's sometimes different, and it's not necessarily tangible, but the people thinking about and working out reasonable accommodation have to think sometimes a little bit out of the box. So in the case of Dr. D, what was negotiated at the time as part of reasonable accommodation was allowing her to come back to work in a graded fashion, which meant that she did not go back to work completely full-time, 8 hours or 12 hours a day sometimes, and with a full workload, but that she started with very reduced hours that were very gradually increased, and that the job task, which the occupational therapist had analyzed together with job analysis earlier, that certain tasks get given to her initially, and that those were also graded to more complex tasks and a higher load of tasks. So, for example, in the beginning, when she went back, she didn't do one-on-one patient consultations. And later, when she started doing one-on-one patient consultations, she didn't do it on her own, for example. So some of that reasonable accommodation also most definitely provided the opportunity for her and for her colleagues to monitor and to rebuild, I think, some of the capabilities and trust that was lost previously. So she then started with a graded return in June, and the return was, generally speaking, it was graded very, very gradually, and it was planned for her to actually take her full workload only by the end of that year. But because of operational requirements, like I said, the kind of environment you can imagine, that it's a fairly under-resourced, almost high pressured environment, it wasn't possible for her to only fully return by the end of the year, and she needed to take up her full workload by September. Another reasonable accommodation that was built in, that was negotiated, was the availability and the presence and for the occupational therapist to do on-site support and job coaching with Dr. D during a work day. And initially, those sessions would be very regular, like once a week, and then it started to taper off until the occupational therapist who acted as a job coach was not involved anymore. So I think one of the important things about this case that I wanted to point out is the amount of time that Dr. D was out of the workplace, which was a full year and a half before she started to go back to work. And we know from statistics that the longer someone is out of work due to injury or ill health, the smaller the probability becomes that they will return. So Dr. D, just trying to move to my next slide, Dr. D eventually returned to work against those odds. I think the element that wasn't there before, previously, when she tried to go back to work twice, is that there wasn't an occupational therapist involved that could direct the process to negotiate reasonable accommodation and implement those in the workplace. The other thing about her case is the employer involvement, which was very strong from the beginning. With the occupational therapist's facilitation, there was some or a lot of education and sensitization that happened, not just with Dr. D's line manager and supervisor, but with the co-workers during a debrief session initially, and then a psychoeducation session. And I saw the questions beforehand about disclosure, for example, about mental health conditions. So those kind of sessions and those conversations took place only once the OT and Dr. D had conversations about what can be disclosed, or what level of disclosure would be acceptable and appropriate, and as well as confidentiality issues. But it was important to have those conversations with management and with co-workers to explain the reasonable accommodation and also the process that was going to be followed with Dr. D coming back to work. The occupational therapist in this case was a private occupational therapist, which means that Dr. D could pay through her medical aid for interventions by the OT, which is different for most people, a lot of people, in employees who don't necessarily have those means. So just in conclusion, this has been said throughout the evening, reasonable accommodation is varied and very much individual. Specifically, I know in our practice, generally speaking, we construct very tailor-made or customized reasonable accommodation measures along with employers and employees. And I think what's important that, again, it's been mentioned throughout, is that the very specific skills that are brought by the OT in the workplace in supporting someone with a mental health condition to be in work and to stay in work is the job analysis skills, the assessment skills in terms of assessing the individual and having the knowledge and understanding about health conditions, and more particularly the impact on functioning, and in this case on work functioning, and then being able to do the job match between what the job needs and what the individual needs and how those two come together, as well as being able to figure out very often, again, with the employee and with the employer, what sort of ways a job can be adapted to allow for reasonable accommodation, that maybe sometimes not even reasonable accommodation, just adaptations in the specific work tasks or in the environment around the person to make that job match more optimal. And then I think one of the things that occupational therapists that underscores all of the skills is counseling, the counseling ability. Thank you. That's all from me.